Hello, everybody, and welcome to this special webinar on the scope of oncology acupuncture. We call it the scope and the opportunities because both are here. Both, it's a huge scope, as you will see, of practice, and a lot of opportunities to help patients, but also to acquire tools that are so needed. And this webinar, I will present it with the team and the faculty of the Oncology Acupuncture Program. So we will start. Let me just introduce myself to people who don't know me. I have 30 years of clinical experience in academic. I've been teaching in many different formats, including a school that we had in Israel, which had 2,000 students. I've been heavily involved in hospital practice, especially in oncology acupuncture and in research. Currently, I'm the president of the ETCMA, which is the European Association of Chinese Medicine. It's an umbrella association of 21 countries and 30 associations. Very challenging these times. I founded and directed a research center, which is unique because it has both a laboratory that we could do research on cells, cancer, immune cells, other laboratory research, including clinical facilities. Before that, I founded and directed the second integrative center in Israel. It's Rusky Medical Center. And we have an interesting congress in Israel, which I'm the president of. I did a lot of research. You're welcome to look at PubMed. Most of it is around oncology and immunology. And I also work closely with the people in the WHO. And I'm involved in the SIO, the Society of Integrative Medicine, and the SAR, the Society of Acupuncture Research. So this is kind of some highlights. And when we talk about oncology acupuncture, we are talking about an area that has so much evidence today, and the evidence are growing by day. One of the main reasons that acupuncture is not well integrated, and I must say in the United States more than in Europe, and in Israel to some extent, is due to evidence. Western medicine language is the language of evidence. The more you can prove evidence, the more you become part of the system. The lack of evidence will always create some barriers. But luckily, there is more and more research, which is like good quality research, which is published over the years. In the last years, we see a year-by-year growth, not just in number, but also in quality. Because quality of research is really what matters, not just the number of research. So this was just a brief search at PubMed. So we have about 32,000 articles, which were put into PubMed. So they have some good basic line of research, 32,000 articles just on acupuncture. And out of them, estimation about 1,400 articles just related to cancer care. It's a lot. And I'll give just a kind of taste. And one of the tastes is also that looks at the scope was the scientific report, which is basically, it was an overview of systemic reviews. An overview of systemic reviews means a lot. It means that you take publications. This overview of systemic reviews actually includes, I'll do it slowly so I won't lose you. It starts that there is research. So in this respect, there is we look at 248 or 250 individual research. Then this research are clustered, let's say all the research of pain, and there is a systemic review of the research of pain. So in this article, they took all the systemic reviews and they reviewed them. So under this kind of, by the way, this is called the pyramid of evidence. And the higher you go, the more robust and valid is the evidence. So obviously, the higher we go on this pyramid, it means that the evidence are more solid. And so in this systemic review, what they did is they, again, screened many more, but eventually came up with 23 systemic reviews that were valid for this publication. These systemic reviews are representing 250 individual research, which I counted, they have 17,000 participants, so the population of participants. So we're looking at 17,000 patients who had during their cancer care been involved in this research. And this is the individual research, this is the systemic review, and this is the overview of all the systemic reviews. So as you can see on this kind of level of evidence, we are going higher and higher. And it means that these findings are valid. They are extremely important as far as evidence to show the validity of acupuncture in cancer care. So just this one is covering this amount of patients. And this is the areas that there's been enough already systemic reviews to cover. So as you can see, acupuncture has been quite extensively researched for, and this I'm showing this to show you the scope and the areas that we are using it on a daily basis with cancer patients, and also that there's been enough research. Again, not all of it in the best quality or not enough, but still it's an aggregated kind of dimension to show more and more the effectiveness of acupuncture. And cancer-related fatigue is a huge area. Chemotherapy overall side effects like nausea and vomiting, leukopenia, these were actually rated as the most kind of validated in this systemic reviews. Then there is cancer-related pains, hot flashes, hiccups, general quality of life, management of dry mouth, especially for patients undergoing radiation because of throat cancers, shortness of breath. There's even some research, good and bad, on lymphedemas, and physiological well-being. There's actually more in the scope. They're also been looking at joint pain, which is not here, and there's a lot of evidence, especially for women who are taking anti-hormonal therapies due to breast or gynecological cancer. So as you can see, the scope is quite large. And from this scope, I want to kind of present one research. So it's kind of, I think it's a good example. I mean, I like this example for many reasons. First of all, it was published at the Journal of Clinical Oncology. And Journal of Clinical Oncology, it's a very high-rated journal. So if you're published, you know, it's not just what you publish, but where you publish it. And oncologists, if you have to show them a publication, best show them from the journals they know and they already they appreciate, and their high impact factor, this is one of them. It has, by the way, a lot of acupuncture research been published in it. And another reason I like this research, it's like a head-to-head research. Acupuncture versus venlafaxine, or Effexor, we know it more as Effexor, so I relate it more as Effexor. It's an SNRI, so it's an antidepressant drug that are given to women while they are taking the anti-hormonal therapy to reduce the hot flashes. So what this research did, and it was done by Eleanor Walker from the Department of Radiation of Oncology in Henry Ford Hospital, and I know her very well, an amazing woman and extremely good oncologist and very open to Chinese medicine, and they have a very strong department of integrative and Chinese medicine at the Henry Ford Hospital in Detroit. So what they did, it's an RCT, randomized clinical controlled trial. They took 50 women and they divide them into women who took for 12-week acupuncture comparing to Effexor. And they actually measured the effect even after 1 year. Okay, so it was 12-year finished, and then after a year, they're still wanting to see if there is a difference between the group, and there's an amazing difference. And the results were that both groups, both the FXR and acupuncture, had a reduction both in hot flashes and depressive symptoms and others, and quality of life. But after 12 weeks, they stopped both the acupuncture and the FXR. And once they stopped it, within 2 weeks after stopping this both intervention, the FXR group was experienced significantly increase in the hot flashes, where there is no hot flashes on the acupuncture group. So this is head-to-head comparing acupuncture to a drug. And you can see when you give them both, each one is effective. When you are stopping them, acupuncture still remains effective even after 1 year. And that really talks about this amazing phenomena of creating some deeper change and a healing process in a patient. So it's the effect. Many times patients ask me, how long will the effect last after the treatment? This is an example that a year later, effect of a series of treatment lasts. And this is a very objective way to verify it in a research. But the FXR Vipax had a lot of adverse effects. Had nausea, dry mouth, dizziness, anxiety. So the patient who took the drug had a lot of side effects. The acupuncture group had no side effects, but actually had additional benefits like increase in sex drive in some women. And most of the women reported an improvement in their energy and clarity of thought and sense of well-being. So again, it shows what we know, drug, which is like one molecule affecting or reducing the uptake of norepinephrine and serotonin in this case. So as long as you take, you upgrade your norepinephrine and serotonin, the patients feel better, but they have a lot of side effects because it goes to more sides. Once you stop it, there was no healing effect in the patient, immediately the hot flashes remain. With acupuncture, we get this deep healing benefit, which exceeds obviously the symptoms, and also go into what I think is the most important, is enhancing the patient's spirit and inner well-being and inner ability, not just to cope with the disease, but cope with their life and cope with everything better. And to me, that's the real challenge of acupuncture. And this is the real strength and the reason, I'll talk in a minute, why we actually created a very unique course to teach oncology acupuncture is just because I saw, and then all the faculty team, which is also working in hospital, knows and saw the same need for acupuncturists to get more and more knowledgeable about treating patients, and especially cancer patients, both during the intervention like chemotherapy, radiotherapy, etc., but also later in recovery and survivorship. So the conclusion of this publication was very strong. When you read the research, you know that on the abstract, the conclusion, will be very kind of peer-reviewed rigorously. But if it's positive, it means that the peer reviewers were very, very impressed. And it says acupuncture appears to be equivalent to drug therapy in this patient. It is safe, effective, and durable treatment for vasomotor symptoms, basically hot flashes, secondary to long-term anti-estrogen hormone use in the patient with breast cancer. So it's a very strong statement. And these patients suffer a lot from the side effects, up to the point that some of them are stopping the anti-hormonal medicine. And for oncologists, and rightly so, they feel that it's a shame because statistically it's been very effective. But side effects are very big. If we look at the points that they use at the research, and I'll do it in a glance, then bladder 23, kidney 3, spleen 6, that was the primary point. It's obvious for everybody with an acupuncturist. It strengthened kidney in, hot flashes are coming from this kidney in deficiency, but especially from the drug, the anti-hormonal drug that dries the chongmai and dries the kidney. So you kind of enhance the kidney in. But what they did rightly is they allow the acupuncturist to do a diagnosis and use more points. So like, especially addressing more yang and heat in some patient, like do 14 and do 20, especially if there was headaches and more dizziness, and enhancing the chi in stomach 36, ren 6, and lung 9, so this the chi high, the sea of chi, and lung 9, which is the entrance of the dachi, and the source point of the lung, all extremely important to add to patients who are also chi deficiency as well as indeficiency. And if there was Hun disturbance, and especially with insomnia, then GV20 or liver 3 if there was agitation due to the yin deficiency, and then for the Shen, pericard, and heart 7. And again, these points are so effective, and you can go combine them in a different way. First 4 weeks, they did twice a week, and then for 8 weeks, once a week. So also in the course, and also when we are reviewing research, we are trying not just to see the points, the best point combination and diagnosis, but also the protocol, which means how many treatments you need to give in order to see substantial and good results. I would like now just to, in a glance, talk about our Oncology Acupuncture Certificate course. It's a very unique international course, and it's built and designed to take someone who is practicing Chinese medicine, even if you're already working with cancer patient, and also if you're not working with cancer patient. Eventually, everybody sees cancer patient in their clinic, either people who had cancer or people who are in the process, or relatives of cancer patients. So we touch cancer all the time. The course is designed from online modules, which are covering quite a lot of things, and it's for 15 hours, and then homework, which are also going deeper into analyzing research and understanding research in oncology acupuncture. And then this is our new first time Corona message. We used to have a face-to-face weekend, but we are now changing it into streaming. So it's 15 hours, it will be actually now a little bit more than 15 hours. And so it will be 4 consecutive Sundays in this respect for the next course, each time 4 hours, where it won't be just me a lot of time, or it was me and an oncologist teaching. We have now a whole new faculty that will present themselves and their CV and abilities. So we will teach, I'll moderate the course, and so we will teach the course as a faculty course, and over this streaming 4 times in a row, or 4 times in a weekly manner. And that we just calculated that together, all this team, we have more than 100 years of professional experience, and everybody also in cancer care. So I think students that will join this special, unique course, as I said, we are doing it for the first time streaming, but we are basically following a course which I give, I think, over 10 times, and I'll tell you in a minute more about it. So that's the basic idea behind the oncology acupuncture course. This is the online modules. When you go to the website, you can watch them. It's been very well accredited by NCCOM if you're in America, but also in New Zealand, Australia, even in China. So the course is very unique in its accreditation, and that's the idea behind it. It's the first time in Chinese medicine history that we are having a course, especially in all the Western world, which is similar in different places. So in Europe, in America, in other places, we have people who have the same basic knowledge and can communicate easily. Acupuncture is so diverse. It's important that we have some core, common, agreed curriculum that we can all share and always come from. So the online course covers many different interventions into the diarrhea, constipation, nausea, vomiting. Each one is a course which is well designed, even nutrition and herbal medicine. The streaming program will include other areas like tonifying immune system, treatment of peripheral neuropathy, hot flashes, joint pain, like we talked a little bit about it, treatment of dry skin, fatigue, insomnia, and more. and presentation of many cases and issues of safety and correct treatment with the cancer patient. Overall, the graduates will immediately benefit not just for practical knowledge, but something that you can immediately implement in your clinic. And it's really a course that gives the confidence to people who treat oncology patients, but most of it can be also applied to the clinic. I mean, diarrhea constipation is not just oncology, and the same with other things. And more importantly, you can better communicate with the medical community. And this is a certificate in the end. The course opens doors in hospitals and clinics, which are now really wishing to get people who are experienced in this field. I know that more and more places are opening and integrating acupuncture in their facilities, especially due to the amount of research and the grassroots movement from the patients. So if you are graduates, you can talk about it. We have already 250 graduates from more than 50 countries. The course has been already once in the States, so we have also many people in different places in the States. So you have a lot of people to share with and also to direct. You know, I'm in Israel, but I'm all the time asked, can you refer me to somebody in Europe, somebody in the States? People now are always have relatives or know somebody in another country, so you can also easily refer to colleagues that you know that have the basic information. So as I said, some of the highlight, it's the first time that people can communicate all across the Western world with the same language. It's well accredited, and I think it's unique, and it's a set of tools that once you have it, it's for life and you can utilize it. The next program will start actually quite soon in June, in the 7th of June. It will be on Sunday, 9 a.m. Pacific time if you're in Paris, 6 p.m. So some will be after sunrise, some will be just before sunset. And it will go the 7th of June, 14th, 21st of June, and 28th. You will get some more information later, but also write if you want more information. There's still no, I think, set up like a page that you can watch it. So, having done all this introduction, I would like to, I'm very proud to introduce the faculty team on this course. It started with I kind of initiated it, and now it's growing more and more into cooperating a whole faculty team that is sharing their knowledge and teaching together. So I would like to introduce Kathy first, and without further ado, I hope you can unmute yourself and
I'm unmuted.
Perfect. So, yeah, sorry, I went.
That's good. No, that's good.
Okay.
All right. Well, thank you. So first, before I start, I really want to just thank very much the TCM Academy and all the co-presenters today for doing this project together. I'm really, really excited about it. And to thank you all I think we have people from all over the world joining us, and for some of you it's quite late. So thank you for being here, and it's nice to talk to you all and meet you from my living room here in Seattle, Washington. So if you can go back one slide, just gonna do a brief overview of my experience. So I've been treating cancer patients for 20 years, both in a hospital setting and in a private practice setting. And those of us who have this focus, you know, I see a wide range of patients with a wide range of cancer diagnoses. And although I've always been an educator, in the last, several years, I've really kind of put a real focus in my own life to helping others treat their patients. So, and I've kind of moved into this new phase of really focusing on helping people learn how to treat cancer survivors. So that's partly why I'm here today and what I'm going to talk to you about. So you can go to the next slide. So why I feel like this is so important is something I really want to kind of emphasize today. So, cancer patients, when they finish their treatment, whether it's radiation, chemotherapy, or whatever, at the end of the treatment, there's typically some sort of like acknowledgement of the end of treatment, right? Like a ringing of the bell or a celebration or, congratulations, this sort of thing. And at this point in a cancer patient's treatment is actually quite scary, because what happens next is extremely unclear. There is no real clear medical pathway for where they go from being under the care of this oncologist in this cancer center to transitioning to off therapy and then into long-term care. So this is sort of the place that I start with, is just this place of transitioning from being on therapy to off therapy and managing these long-term effects that come with cancer treatment and cancer itself. So you can go to the next slide. The thing that's important is, sorry, I just want to say one other thing, is that up until this point in a patient's experience, they've been doing something very active to treat their cancer. So even though that treatment has been difficult, painful, sort of consuming their life and all this sort of thing, financially burdensome, they're still doing something active. And at that point when the bell rings and they sort of transition to off therapy, suddenly they're doing nothing. And it's an extraordinarily stressful time for patients. And for some patients, in my experience, just as stressful as the initial diagnosis itself. So in order to kind of, I thought it would be good to kind of give you some ideas about things around when we talk about cancer survivorship. So this is just sort of ideas for you to think about, this sort of thing. So what is survivorship? Right now, we are in an interesting phase in medicine around these sets of patients. So up until maybe about 5 years ago, cancer survivorship was defined as somebody who had finished therapy, a course of therapy, and now was sort of cancer-free. That's changing now. It's not changed everywhere, but it's sort of this movement to sort of change this idea of cancer patient versus cancer survivor. And now we see patients in many cancer centers being sort of put into this survivorship category at the beginning, really at the initial diagnosis, right? So we now know that cancer is more and more becoming a chronic disease, right? The idea that patients are living with cancer, right? There's not just this you have cancer or you don't have cancer, that there's actually another category. So this movement away from using the term survivorship, although happening, we don't really have a replacement at this point. So it's still what it's mostly the terminology that we're using. The other terminology piece that's interesting around these patients is around the idea of the battle that they're doing, right? The fight that they're doing. And this movement away from this terminology around fighting cancer or getting through the treatment and beating this thing. Because quite frankly, what happens for patients, as many of you already know, is there's a tremendous amount of guilt that happens at the moment a cancer diagnosis occurs, right? So patients are, struggling with coming to terms with all the things that they did or all the things that they did not do that led them to the place where they got diagnosed with cancer. So there's a tremendous amount of guilt just based on the fact that they developed the disease. But then even maybe more significant is this responsibility that the patient seems to have in surviving the disease, right? So they're going to receive this therapy, which is, pretty consistent across cancer centers around the world, chemotherapy, radiation, surgery. And it's sort of up to them as to whether or not that therapy works, right? Like whether or not they come out of the other side of it without having a relapse or without the cancer metastasizing. There's a lot of responsibility on the patient, right? So these are things that the patients in the transition from being on therapy to off therapy, this gets very heightened because now, since maybe what they did, some of their decisions that they've made about their life have led them to here. Now, what do they need to do to prevent getting back there, right? So it's a really, really intense time. And certainly the reason I'm saying all this is because I think it's also an enormous opportunity for patients to utilize our medicine for us to as a profession, to kind of help. So I think you can, next slide. So maybe it's true, but maybe not everyone who's in this webinar will if you're just in private practice, maybe not have much exposure, significant exposure to treating patients who are undergoing active therapy. I mean, I think more and more that's becoming less true, but for sure, all of us will be seeing patients who have either had cancer or are living with cancer. So this is a really, really important population of patients for us to be very, focused on learning how best to treat them. So, I mean, the statistics in the United States are pretty staggering. I mean, the overall cancer death rate, the change from the 1990s till now is pretty significant. This is not true for every individualized cancer, but it's an overall, and this just continues to grow. This number changes all the time, and it continues to go up. So, I mean, just the prediction that we will have 26 million cancer survivors living in the United States by 2040 is really speaks for itself. So, this survival rate every decade, exponentially increases. So now we have a massive amount of patients who have very unique needs that are directly related to the fact that they had and were treated for cancer with no medical specialty. So you could go to the next slide. Basically, when somebody ends cancer treatment, now this is not true everywhere, but for the most part, this is still true. Patient ends cancer therapy, they pretty much go back to their primary care provider, right? There's no medical survivorship specialty. I think that's going to change, but currently, right now, we don't really have that. The next time they're going to see their oncologist is for the scan. So where do they go to have, to help manage the late effects from their treatment or make, health promoting decisions around nutrition and things like this? So now there's been a response to this in the medical community, at least I can only speak for the United States, which is that now, just in the last several years, really, several major cancer centers have now what we call, quote, survivorship programs. Now, what's very interesting about this to me is I know quite a few people who work in these programs, and every single one of them will tell you that they have at least a 6-month waiting list for patients. In fact, a colleague of mine who I spoke to 2 weeks ago told me she has a 2-year waiting list to treat cancer survivors because they're desperate for help, right? And there's no, again, there's just no place for them. They don't have anywhere to land, right? So, and then the other thing that's really important is acknowledging the individuals who have, advanced disease, right? Or people who have, problems such as that might be related from surgery that they don't really qualify for certain aspects of survivorship programs. So they kind of get lost, like from transitioning to not being on therapy into this void, basically, because they don't really qualify for these survivorship program activities. They don't really have a medical provider that really specializes in managing their unique needs. And it's sort of this they get lost. So again, another place where I feel like we can be. Because quite frankly, I believe that our medicine is actually the solution to this problem, both for the patients and for the medical systems. In my mind, and I work very closely with a lot of oncologists, so I do have this happen to me. But what I would love to see happen is that a patient who's coming off therapy for cancer says to their oncologist, because they all do, every single one of them, what do I do now? And instead of the oncologist is saying, go home, rest, try to recuperate, and we'll see you in 6 months for your scan, they sort of say, well, why don't you try Chinese medicine, right? For all these things, right? So that's sort of my dream, and for us to get there, I feel like as a profession, it'd be good for us to develop some expertise around this as well. So, so there's 3 things that I think a patient, where I think we come in. One is to, patients after any kind of cancer therapy or cancer diagnosis they have a lot of recovery in front of them, right? You'll hear more about that from another presenter today, but they really have like this, they need to recover, right? To get back to baseline, recover their health. They also are going to have late effects, right? Or long-term side effects from the treatment, right? Whether that's pain or fatigue or, there's some very common ones. And then there's some not so common ones, depending on the patient and their particular experience. But there's typically some aspect of late effects. I mean, even in early stage breast cancer patients who, are cancer free and will never and don't have recurrence of disease, they all suffer side effects. Many do, I should say, more than 50% long-term late effects. So this is a big deal. And then the third place, which I think is very, very big opportunity for us, is around, strategies for, really helping patients on an individualized basis, because we're not protocol based, right? So on an individualized basis, really develop strategies for that patient to maintain their health, right? This is a highly motivated demographic of patients. They want to learn how to be healthier. They want to be healthier, and they want to help prevent their cancer from returning. All these things, right? So to me, Chinese medicine is the best place for them to land, right? So I'm very passionate about this. I'm very passionate about it for the patients and also for the profession. So it's basically why I'm focused on it, and I hope to see you all in future class so we can talk more about it. Thank you.
Well, thank you, Kathy. And it's just brought to my mind, there's been a very interesting research about the effect of acupuncture on cognition and memory.
Yeah.
And almost, I think it's like 80% of cancer patients suffer from some kind of lack of cognition and memory for years.
That's right.
And they did research. I was like shocked when I read it. They went into biomarkers and showed the difference between acupuncture and a control group, and again, even after a few months of acupuncture. So I think, as you say, survivorship is one of the biggest area where it's so needed. And we have so much to offer, and Western medicine has nothing, or very little, I can say. I mean,
well, no, it's true, because in many of the late effects that patients experience, just like you're mentioning, like the cognitive and then fatigue and things like this, even pain, these are things that are typically not well managed in Western medicine, right? We don't have a pill for fatigue. We don't have, our pain management options have a lot of side effects. So I agree. I couldn't agree more, right? We're very good at these things, just as a general rule.
And I was also totally surprised, that again, there is more and more research showing it. And I'm sure that more and more people will eventually be aware that, this is where they can get help. And it's a quality of life. I mean, quality of life is the basis of life. So, well, thank you, Kathy.
Maybe even preventing relapse, if we want to get so bold, right? I mean, if patients are well cared for during this transition and in the early stages of their recovery, it's interesting to think about what the long-term impact of that might be.
Oh yeah, I can say I definitely have a lot to say in it, and even our next research looks to also at reduced of recurrence in cancer patients. So,
right.
I'm glad to introduce the next faculty member, and thank you, Kathy, with Jonathan Ammen. And Jonathan, apart from being a very old friend for more than 30 years, is an amazing practitioner. And I'm so happy you're joining us and willing to share from your experience.
Thank you. Thank you, Yair. And it's been a pleasure to get to join the team here and have a role in this. And some of the things that you were just saying, Kathy, I've been scribbling notes here. Hopefully I'll come back to some of the points you made and try and reinforce them and speak to my own interests there. I'm particularly interested in hospital-based practice. I'm a graduate of the New England School of Acupuncture back in 1982, and after that studied pretty much at the same time as you did, Yair, with Ted Kapchuk. So we have a similar mentor there. Later, I returned as the chair of Chinese acupuncture studies at the New England School. I've been interested in hospital-based practice since the early 1990s, and took a sort of winding path through that, ultimately landing at what we now call Beth Israel Lahey Health in the Boston area. I'd previously done research work at Massachusetts General Hospital and had an appointment at New England Sinai Hospital, and also did some sports medicine work at Boston Children's Hospital, taking care of dancers in the Boston Ballet Company. Anyway, at Beth Israel, let's go keep that slide for a minute. Yeah, keep that one. Thank you. I spent some years in the pain center, also doing physical medicine and rehab work, internal medicine, and then was recruited in 2010 to join the oncology program, basically starting the integrative oncology program there. So that's been my primary focus. I see patients in clinical practice, both inpatient and outpatient. And that's one of the topics that I like to talk about are the similarities and differences between these two populations. And the techniques are very much the same from one to the other, but sometimes the goals of treatment and the role that the acupuncturist plays can be quite different in each. Sadly, some of my most profound current training comes from the fact that I've been taking care of family members, close family members who are gravely ill with cancer. This has fundamentally changed in a positive way, I would say. It's deepened my understanding and appreciation for this work and my ability to be present with my patients in a way that's helpful. Anyway, let's jump ahead to the next slide. Okay, great. So as going forward with this treatment training process, I'm particularly interested in teaching about the nature of hospital practice as distinct from private practice. Private practitioners, and I had a large private practice for many years. We're much more solo practitioners. We're not collaborating so much as part of a medical team. Within a hospital-based practice, and particularly in oncology, we are team members. Oncology is a team sport, and no cancer patient can really get through the process without many different people being significant parts of their care, important parts of their care, from the oncologist to the phlebotomist, to the infusion center nurses, to the radiation oncology people. And as an acupuncturist within that setting, we have to be understanding our role within the team and have a place there. We have to become good collaborators. Interestingly, though, our medicine has not yet been integrated as part of the standard of care. And so the role that we play can be very different in one institution to another, and is constantly changing as the research comes out and as people's perception, particularly practitioners' perception, shifts. For instance, in survivorship programs, we have a survivorship program at Beth Israel Lahey where I work, and I'm part of this survivorship team. I'm constantly reminded that I must perform my role as an educator to my colleagues about the benefits to their patients from receiving acupuncture, and so that I can be more and more fully integrated into the care plans that are organized. And this is a part of what it takes to become an oncology acupuncturist, particularly in a hospital setting, is to become an educator, to become a teacher, someone who can give a presentation in front of a tumor board, and as well as collaborate on the fly with other members of the oncology team. That's something that I hope to be able to teach about, as well as perhaps even mentor people through the process through one-to-one connections.
I just want to say, Jonathan, because I've seen you practicing and demonstrating, I think one of the real key essences that you bring to the team and to the people who will study with us and with you is this hands-on abilities which are unique. After 30 years of practice, there's some magic in the touch. And putting together the touch with the needles, I think this is something you have mastered, and especially in the field of cancer care. So I'm so happy you are here and here with us.
Great. I'm I feel it's mutual. And thank you for highlighting that interest of mine, both the physical connection that we make with our patients, as well as the Shen connection, the spiritual connection, are unique to our medicine. And we have permission and we have the ability to make these kinds of connections with our patients in ways that conventional care practitioners are they're not taught to do and not encouraged to do. Not to criticize, it's just simply that they don't have those tools in their toolbox. And as an example, as Kathy was talking about, patients who come away from their plan of care and they're set adrift without a place to go, the kind of connection that they've made with a Chinese medicine practitioner can really be an anchor and enable them to move forward in a way that that would otherwise not be as helpful for them ultimately.
I think you have highlighted something which is really key and sometimes ignored, but patients give us a permission to go very deep. And I think this permission requires a lot also on our side. So thank you so much, Jonathan. And I would like to present, Jennifer, who is also a good, very close and good friend that has so much experience and so much has been done both for the whole field of Chinese medicine and acupuncture in the States, leading a special journal and ASA and other things, but the floor is yours, Jen.
Thank you. Hello. Most of you know me as the editor-in-chief of JASA, the Journal of the American Society of Acupuncturists. And I've been a journal editor for 10 years now, but I've been a clinical acupuncturist for 30. And in that time, I've worked at 4 different hospital-based integrative oncology cancer centers. Incredible experiences. Right now, I am with, for most of the time, I've been with Indiana University School of Medicine. We are the largest medical school in the United States, and we have incredible resources to study the mechanisms behind the effects of acupuncture. And I'd like to talk a little bit about that today. Can you advance the slide, please? Okay, so this is my favorite slide that explains why acupuncture benefits the immune system. It's fantastic. I saw it the first time when I was taking a biology class in college. It is from Campbell Reese Biology, Pearson, 7th edition. I actually got permission from Pearson to reprint it, republish it in a book chapter that I wrote with collaborators at Indiana University. So look at this. Isn't this incredible? The needle goes into the skin, and what happens? The body reacts to that needle. The blood vessel, which is normally pretty small because red blood cells are normally what fills the blood vessel, and they are pretty small. But when the needle comes in, the body reacts to that needle because it's a foreign object, and there's this defense mechanism that happens. White blood cells, our immune cells, are twice the size of red blood cells, as you can see in this picture. So the capillary has to dilate to bring all these white blood cells to the area to kill the bacteria, kill any pathogens that came in with the needle. Even though our needles are sterile, our pre-sterilized disposable needles, the body still reacts in this way. And when the body reacts in this way, the brain says, oh, we've got to make more white blood cells because these white blood cells are coming to the area where the needle is, and there must be something going on, and we've got to make some more. So, I mean, isn't that just a beautiful snapshot of how acupuncture improves the immune system? Next slide, please. So if you want to get into the research, there's an awful lot of research, basic science research in the effects of acupuncture on immune cells. Many researchers have gone as far as many research teams have separated out the different cells. They can do it with a device called flow cytometry, where they're able to separate the different types of white blood cells and count them. So you can simply go on PubMed and Google it, and you'll have hundreds of articles to go through. But I was really interested in looking for a human subject study, and I pulled this study because it's our good friend, Dr. Weidong Liu from Dana-Farber at Harvard, Dana-Farber Cancer Center at Harvard. And Dr. Liu, I believe this one was in, 2009. It was a sham study where he compared acupuncture with a sham style acupuncture. 21 women who were newly diagnosed but had recurrent ovarian cancer. They found that the acupuncture indeed increased the white blood cells. And this is important because we know that chemotherapy decreases white blood cells. For many, many years, it was thought that it wasn't a good idea to do acupuncture on patients who were undergoing chemotherapy because we could cause infection. And now, after so many studies have been done, we found that it's actually the opposite. The acupuncture improves the immune system while the patient is going through chemotherapy and could reduce chemotherapy dose reductions. So that's really, really important. Next slide, please. So I wanted to talk about just one case to kind of give you a really good example of how acupuncture so beautifully whipped this gentleman's immune system back into shape. 65-year-old male, chronic low back pain, prostate cancer. He had completed chemotherapy about a year and a half prior, had radiation and surgery, multiple comorbidities. When he presented at my office, we really didn't expect him to be as ill as he was. He was in a chair, and he had a very unhappy, open, weeping wound on the inside of his right leg. He told me that it had been open for 16 months and he was going through wound care, but it just would not heal. I gave him acupuncture twice a week for 3 months. Thankfully, his insurance covered, so we were able to give him the dose that was required. Next slide, please. So this is the first day that I saw him, and you can see that the circulation is not good in the legs. There's that wound. There's stasis dermatitis. That's the dark color in the lower legs. He was not able to walk because of both numbness and pain, which happens with people who have chemotherapy-induced peripheral neuropathy. They have numbness and pain at the same time. It's a little weird. The picture on the lower right is a fungal infection on the ankle. He had multiple fungal infections throughout his body on the skin. And that is, a sign of a really tanked immune system. So this guy just really wasn't doing well. Next slide, please. Treatment strategy. My primary focus was to strengthen his immune system and get this wound closed up. so that he could get better. At the same time, I was very interested in bringing back the sensation in his legs, the neuropathy that he had. And go to the next slide, please. And it worked. 3 months later, that's the wound. It's completely healed. He has better circulation in his legs. And in that time, he transferred from the wheelchair to a walker, then the walker to a cane. So he's now walking on these feet. Next slide, please. At Indiana University, we're really looking into some fantastic, exciting things. We have Fletcher White is, Dr. Fletcher White in the corner is a neuroscientist, and he is a mentor of mine. Dr. White and a very large team did multiple studies on animal subjects and a few human subjects, and they were able to find that certain acupuncture protocols release MSC stem cells, mesenchymal stem cells, into the periphery, into the bloodstream, and we can pull the stem cells out of the bloodstream and test them and investigate them and try to find out more about what's happening with the immune system, what's happening with the tissue. Are these stem cells possibly helping with tissue repair? Are they helping with nerve repair? We don't really know, but it's a fascinating area of research. And that's all I have for today. Thank you.
Okay, I'm sorry, for some reason I wasn't able to hear you, Yair. Can you hear me?
Oh, sorry. Could you hear me now?
Yes.
Oh, sorry. I have two ways to mute my mic, and one is local, so I did the local. So I'll say it again. I'm happy to introduce you, Rachel. First of all, I say bye to Jen, and thank her for her contribution and her experience, both in cancer care, but also in advancing the whole field of Chinese medicine. And you, Rachel, you're also very unique in advancing e-learning, and also especially e-learning via modules like streaming to a whole community of Chinese medicine people who are doing doctorate programs, and you'll talk about it soon. And I'm so happy you joined our team and sharing your experience, especially about treating older patients. And I say that cancer is more common in older patients, and there is a close relation between aging and cancer, aging of cells, aging of life, and the development of cancer. So without any further ado, welcome, Rachel, and it's your floor.
Great. Thank you so much, Yair. And I'm very pleased to be part of this team too. Could we go to the next slide, please? So that's me. I am affiliated with the Pacific College of Health and Science. We had a name change starting in January. We used to be PCOM. Some of you may know us as PCOM. And as Yair said, I was doing Zoom before it was cool to do Zoom. So I've done a lot of e-learning as a department chair of transitional doctorate program, and the courses that I teach tend to have to do with research. So I teach a lot about research, and I have long been interested in three things, which are cancer patients, treating older adults, and research. So I'm going to talk to you about the intersection of those three things today. And can we go to the next slide, please? Yeah, so as Yair was saying, there is a relationship between cancer and aging. And it's interesting because there's not an agreement scientifically as to what aging even is. Is it, some people hypothesize that there's a natural senescence, that our cells reach a certain age and then that's it. There's a timer on them, in essence, and the timer ends, or it's like, if you remember the Wizard of Oz, when the monkeys have Dorothy held in captivity and they turn the timer, they turn the what do you call it, the sand thing, upside down, right, and the sand runs out and her time is up. So there's this theory of senescence that it's like that. But there's other theories, people who believe that it's not, and that the cells are more like something mechanical. If you keep fixing the parts on your car, then it can keep going theoretically for a very, very long time. But we do know what it looks like. We know what it looks like when someone gets older and when things start falling apart. And we see that happening following cancer treatment. Interestingly, a lot of the evidence that we have comes from studies of pediatric cancer survivors. There's a very good rate of survivorship now among people who go through childhood cancers. And so some very long-term studies, they're called longitudinal studies, have shown some other alarming things about what happens to people in terms of fairly young people who just seem to be aging prematurely, who have been through childhood cancers. And can we have the next slide, please? Okay, actually, I'll just keep talking on the previous slide. That's fine. So a lot of the evidence comes from this particular cohort called the Childhood Cancer Survivor Study that began as the long-term follow-up study in 1994. Started by the University of Minnesota. And at this point, the group of people they've put together, they're looking at them retrospectively, so going back in time and looking at what happened with them. But they've got 36,000 people in this cohort. So that's a lot of data, and a lot of different studies have come out of it. One of the things they've found is that some survivors of childhood cancer have such declines in their muscle strength, their mobility, their endurance, that in effect, those abilities in them are the same as people who are in their 60s and 70s. And these are people who are in their 20s and 30s. And their muscle strength and their endurance, et cetera, are like people who were in their 60s and 70s. Now can we have the next slide, please? Thank you. So there haven't been many studies of older people. In fact, this is true across research, not just with cancer. But one study of people who are now healthy, at the time of this study were healthy, but some of them had a history of cancer. So again, they're looking back at their health in time. So these people are middle-aged, older age, and they found that the people who were older, a combination of older age, that means greater than 65 years, who had a history of cancer, they were much more likely to fatigue easily, to lose their endurance than people who had not had cancer. So again, those are kind of markers of age, losing your ability to keep going. We also know that older cancer survivors have more limitations in what they can do, and they have a lower quality of life based on many different parameters. Again, than people who would be similar to them but have not been through cancer. And next slide, please. Now, there are many different kinds of cancer, and we may even consider them as different diseases. But the sorts of treatments that we use, the modalities, are essentially the same. There's surgery, chemotherapy, radiation, hormone treatment. They may be used in different amounts and different types on different people, but those are the modalities. And I'm only going to talk about chemotherapy today, which is considered to be the most toxic to the aging process, I would say. And we know some mechanisms. Telomere lengths, you may have heard of telomeres. That's that bit on the end of the chromosome that basically protects the chromosome from deterioration. And the more times the cell replicates, the shorter the telomere gets. It loses a little bit with all those replications. Eventually, it just loses so much that it can no longer protect the cell. And that's a part of aging. But it can happen due to other things as well. And chemotherapy has a really bad effect on the telomere length. They get shorter sooner. They lose their ability to protect the cells. DNA, of course, the chromosomes are involved in DNA. And the chemotherapeutic drugs have a poor impact on DNA as well. We know that as people age, again, similarly as with the length of the telomeres, the body's natural ability, the DNA's natural ability to repair itself, to repair the cells, that declines. So that's already declining in older people, but the chemotherapy just gives it a double whammy. And again, we know this from the childhood survivors, but when you have people who are already going through this decline, it's an additive or even a synergistic effect. Then there's some particular types of cancer drugs. The vinca alkaloids, those include vinblastine and vincristine. These are often used, for instance, in lymphomas. And other ones, the taxanes, those include paclitaxel and docetaxel. Those are often used in things such as ovarian, breast, or non-small cell lung cancer. And some of the serious side effects of those have to do with peripheral neuropathy. And if you've treated any cancer patients, you know that there is often this effect of peripheral neuropathy from chemotherapy, which is very difficult to treat. And my own mother, who went through breast cancer treatment, she just had peripheral neuropathy that didn't seem to respond to anything. So it's a big complaint. So that's another way that it can increase the aging sort of process. Cognitive decline, this was mentioned earlier, I think by Kathy. And so that's another area where there's this chemo brain we've heard about, but cognitive decline is a great concern of older people, particularly women. And there's a study showing that cognitive decline was more prevalent, higher risk for breast cancer patients who had gone through chemotherapy. And next slide, please. Great, thank you. So frailty, this is something, and you may have seen people with the profile of this woman. We just look at that and you think, oh yeah, she's frail. What it means biologically or physiologically, it is a phenomenon that we can define, and it's often defined as a loss of reserve capacity. That is, the gas in the engine, or the petrol, depending where you are, has run out. It's run very low. There's not much left. When you step on the pedal, there's nothing there. The car doesn't pick up. And we may speak of it in terms of specific organ capacity, cardiovascular capacity or lung capacity, reserve capacity. It means that the body just doesn't have its resilience. The organ systems don't have the resilience. It is a predictor of certain bad outcomes, again, chronic disease, disability, even death. Now, something else that was seen in this large cohort of childhood cancer survivors was that the rates of frailty among these young people was much, much higher. Again, you don't expect to see it in young people at all, frankly, but much more comparable to people who are decades older, and especially for women. And there was one study looking at people who had survived childhood cancer, survived at least 10 years. Now, of those people, they used this particular criteria to say whether they had pre-frailty or frailty. The rate of pre-frailty for women was almost 1/3, 31.5%, whereas it was 13% for men. The rate of frailty in these people was 13% for women and 3% for men. But these people, they were looking at the median age was 32. And you do not expect to see this kind of frailty in a 32-year-old, but it was much, much higher for women.
I just wanted to add, because if we take all of this into Chinese medicine, and we discussed it before, it's so obvious that everything is to do with kidney weakness.
Yes.
That, and kidney is also the origin of all the extra meridians. So we see the Ren Mai, Du Mai, Chong Mai, and kidney weakness. as a result of all this treatment. I mean, their toxins, they go deep, they go to the bone marrow, gain kidney, and they go to the brain. So.
Yes, and interestingly, so of some of the survivors, again, from the cohort, the two types of cancer that led to the greatest limitations were bone cancer and brain cancer, which is really interesting when we think of it from a kidney point of view.
Mm.
And for myself, I tend to use points that I actually use a lot of moxa if the patient can tolerate moxa, particularly on REN4. REN4, REN6, if they're comfortable lying face down, I might do DO4. Also UB43, the vital region shoe. And I've had very good results with that. And again, I think Jonathan was talking about experience with relatives who had cancer. So both my parents, as well as my sister, in fact, had cancer. And my father, he was quite old, in fact, and he couldn't get up off of the sofa. And I would I didn't use Mox on him, but I did use needles for kidney and particularly REN4. And he would get up and start doing deep knee bends. I don't know how much it was the placebo effect. He thought he was getting better, but for a whole afternoon, he'd be bouncing around. The next day, he'd be back in bed. But it does have a very potent effect.
I mean, I see it so often, patients come to the treatment room so old, I can say, and they go out younger, So even the secretaries are the best one to attest for it,
Yeah.
Look at this patient.
And depending on, and depending on the state of the patient, sometimes they're very weak, very poor health, and the relief they get may only be for a few hours or for a day, but that's a very significant time. And this is part of the thing with research, actually. If we could go to the next slide, please. Yeah, so there are certain disparities with older patients. Another reason I'm very interested in them. And before I look at the disparities in healthcare, disparities in research, due to the way that research is conducted, and researchers, particularly when they're conducting interventions, they want to give themselves the best chance. They want to give their intervention the best chance of having a good outcome, an optimal outcome. And choosing old people who are really sick is not a good way to get a good outcome. So older people are very often excluded from research because they have more comorbidities. Just being older, you don't bounce back as well. So when you treat them, you also don't get those great results where people jump up and they're all better after a couple of treatments. You have to keep doing it. And actually, some of my research and my own experience is that just regular acupuncture treatments for older people, whether they're cancer survivors or not, it is super beneficial. And it's unfortunate that in the United States, insurance companies want to cut everybody off after a certain number of treatments. You've done enough, you've got to be better. Because it doesn't work that way as the body is aging. Just one more quick disparity when it comes to care as well. So this was a German study, and they were looking at the health records of over 13,000 patients. These were patients of lung cancer. And they found that the interventional treatment for their tumors, as well as palliative care, much less used the older the patients got. Even opioid prescriptions for pain, antidepressants for depression, much, much less used. In fact, of the oldest group of patients, that was 85 and up, 66% of them were not having any care at all. But yet pain is consistent across people regardless of the ages that they are. So why is that? The authors of this study postulated that maybe it was because the research, there was no good research for the oncologist to tell them, here's how this treatment works on older people, because it just isn't there. That may be a reason, my own suspicion is that it's both patient priorities. Sometimes older people, they say, I've lived a long life, I've had a good run, I don't want to spend my last months, years, whatever it is, going through this really invasive treatment that's going to devastate my system. Somewhat, but I think that it also comes from the healthcare system's priorities.
I have a friend who is one of the greatest researchers, Hugh McPherson, and he always says, we compare acupuncture to usual neglect. So I think it is true. Older people tend to sometimes be neglected in their care. I must say that the one that misses most the acupuncture treatment during the corona were the older patients, and I was surprised how they were aware that lacking the acupuncture treatment really deteriorates their health, and their regular acupuncture keeps them, at a much better shape. So I think this has been a very good example.
Yes, and really sadly, we had to close with Pacific College, the clinic that I work at, the free clinic for low-income seniors, and we had to close that quite a while back because they're at high risk, of course, of getting COVID. But I think Kathy was talking about how many cancer patients, cancer survivors there are, in the United States, and 60%, at least 60%. In 2016, it was 60% of them were 65 and up. That's projected to increase to 2/3 by 2020, 2030, or 2040, depending whose projections you look at. But that's between 8 and 11 million people of that age. So kind of some takeaways. One thing that I have noticed from my own clinical experience, pain and depression are really common symptoms in older people, regardless of whether they've been through cancer or not. And regardless of what they're coming in for, they may be coming in for some other thing, nothing to do with depression, but it turns out that they do have depression. Also, pain is very prevalent. Studies of multimorbidity, 3 or more common chronic conditions, show that people with multimorbidity, pain is the most frequent, most bothersome, most prevalent symptom that they have. And often it's very severe and not well treated. So I think in your older cancer patients who you're seeing, and I usually see them, I don't work in a hospital system, so they will be coming to a private office, sometimes after they're done with their treatment, sometimes while they're still going through it. But pain is very important because pain just depresses everything else, mood and everything else, including the ability to bounce back, I think. But also the Shen, really important to treat the Shen, their spirit, the Jing, as Yair was saying, because that's just devastated by chemotherapy and radiation too. And to support the kidney function, we know that Qi in blood, the spleen stomach function, is really messed up by chemotherapy. But so is kidney function. And actually, when I think of frailty, I think of Ruth Bader Ginsburg. Now, I'm not her doctor. I can't say that she has frailty, but when you look at her, she looks like she's frail. She's this tiny little woman. She's been through multiple rounds of cancer, and yet she has done things in her life to keep herself pretty fit and healthy. So I think even for people who go into frailty, we have options to offer them that we can't reverse aging, but we can do something that sure makes things a lot better than they would be otherwise, to use the technical terminology.
I think that, again, one of the strengths of acupuncture is a 3-dimensional approach. And in this respect, I would say, even that we look at the Shen, Qi, and Jing, the 3 treasures, when we treat a patient, we are addressing much more than just one aspect. And a lot of time, the Shen will be the one that pulls everything forward. And to me, this is the strength of Chinese medicine as a science, comparing to regular care that takes care of the body, or a lot of time will neglect something else. So I think this 3-dimensional approach for these patients especially is so meaningful, and that's what I see on a daily basis.
Yeah, I agree. It's tremendously important, and you see the results, and that's tremendously rewarding.
Perfect. Well, thank you, Rachel, and so much, and everybody. I'll just say a closing word, and I'll close in a minute the slide. And then we'll move into a short questions and answer to the whole team. I mean, it's been very long, so we'll do a few kind of questions and we'll try to answer them together. As I said, I'm very thankful for this faculty team, amazing people. And this is a very unique course that we are going to run as a team. And I think the tools that we'll be able to provide will be really indispensable and be used all the time. Eventually, Chinese medicine is growing for a reason. And the main reason is because we can take care of so much suffering, which is produced more and more. And somehow this ancient system of medicine can address it. So I'll just close the kind of formal presentation and open to everybody of the team to join to answer questions. And especially now and always, all the best of health to you, and be well, but we'll stay here now for questions and answer. And thank you very much for joining us from all over the world. So now slowly, I think everybody will come up. And it's another opportunity to thank Guy Triber, who is doing all behind the scene work and making it all happen. So I think everybody can unmute and put their video on, and I will start to look at the questions. Let's see, questions and answers. I'm always opening a wrong one, so now I'm here. Okay, I'll take this question, although it's a kind of problematic. Good evening, morning, he says. It's Ribeiro. When talking of energy, are you talking about the ATP production? I'll say a word about translational medicine, which means, we take Western terminology into Chinese world. So I think we have to keep some borders. So I think ATP, we are going very much to the cellular level, and the strength of Chinese medicine talking about qi is talking about this phenomena of energy turning into matter and matter into energy, and covering something which is much bigger than realizing the cellular production of ADP by in the cell. But anyone else take on this question, you're welcome. You have to unmute yourself if you want to speak.
Okay, I'll jump in. It's not unusual for us to get this kind of question. What do you mean by qi or energy? And one of the straightforward answers that I often give, particularly in a Western medical setting, is that this word is often used to describe both function and capacity for function. We say in Chinese medicine, the qi of the stomach is to receive and ripen the food and pass it on downward in the intestine. So that's its function. And the capacity, or the qi, or the function, when there is insufficient qi, the stomach does not perform that function properly, and you get rebellion or things coming back up. So we're not necessarily talking about something that is quantifiable in the sense that you can describe the ATP cycle, and yet we're talking about a description of reality, a description of phenomena that are easily observable in the world. This is one of the big debates in science and in philosophy around the fundamental ideas in Asian medicine.
Well said. Anyone else on this? So I'll answer. There's another question which is simple. If we can recommend a few articles, we'll try to put some maybe later and post to anyone who is interested. Overall, the secret to find good articles is to go to PubMed and put acupuncture oncology and see if they're published, for example, at the JCO. But we'll be happy to provide some links to good articles. Then there is a lot of practical questions. If the streaming will be recorded, yes. If it includes herbal medicine, very little, mainly acupuncture. We just touch on some herbal research. I've been part of quite a large herbal research with a lot of collaboration. So we are touching on it, but we'll be mainly focused on acupuncture this module. And let's see if we cover lifestyles advice recommendations. So I think to a certain degree, again, with the time we have in the course, we'll focus very much on clinical acupuncture, but everybody, especially around cases, will share also their experience. So advice of lifestyles, herbs or diets will come with cases. It's not in the main structure of the course. It's a very intensive course in acupuncture. So there's more like practical. I want to jump to something that we can. Okay, I'll keep this one kind of as a closing one. Although there's many questions, but I think at this time we'll kind of try to conclude. What's the difference between chi and energy? I don't know. We went into philosophy a little bit, and it's okay. Well, anyone who wants to answer this kind of very philosophical question?
I think
I will attempt, but
we probably all have an idea about what we would say.
so I'll maybe pick up some more practical question. Again, I think it's very much the difference between Western mind and Eastern mind. I think we are all Western, so we think with the Western kind of ways of how we want to grasp the world and hold to it. Chinese medicine does something which is everyone who I think studies it and practices it. At some point, we are so frustrated from a medicine which doesn't want to go into a box. We like boxes and we like things, this is A is causing B is causing C. Chinese medicine talks about the interactions. Even in biology now, we have like molecular biology, but we have system biology, how things are interacting with everything. And in this respect, chi is a better concept than energy, and it's very unique to the way we understand all the changes in the world. So I would like, and I'll pick like a more maybe practical questions for then. Okay, that's a very provocative question. So I would like to end and hear your comments about it. In my work with cancer patients, I've often noticed that patients had powerful emotional trauma shortly before developing cancer. Would you like to comment? So anyone that would like to comment on it?
I'll say one thing, which is that I think it's important to be careful not to, because as Kathy was saying, patients already have, cancer survivors, I'll call them, already have a level of guilt about what did I do to cause myself to get this disease. So I think you have to be careful about looking at them and pinning on, well, you had this strong emotional response or you were out of control. But I do think in my own mind, cancer is multifactorial. There are a lot of things that cause it, and emotion may well be a component. I did note in my own family, my mother had breast cancer. She had a lot of what I would call suppression of frustration, liver qi stagnation, which may go to the breast. My aunt suffered tremendous grief when my uncle died suddenly, fairly young. She had lung cancer. I mean, the lung is related to grief. Are those things, would they have developed cancer anyway, but that's where they ended up having the cancer because of the emotion? I don't know. I think it's interesting to speculate about, but I would be cautious in conveying that to the patient who's already probably feeling guilt.
Although I'll second that for sure. But I have the same experience about the person who posed the question of patients actually making that connection themselves. So that sometimes that comes up in the history taking. But the only thing I will add is that emotions are one of our primary causes of internal diseases in the whole medicine. So I think you can't think about causes of cancer and not think about emotions that are unresolved, excessive, that sort of thing. But yeah.
I'll just say two things about it. One, we have to differentiate between a cause and a trigger.
Mm-hmm.
And the third thing, that when I started treating cancer patients, I thought that most cancer will come from some trauma or emotion. The more I treat cancer patients, the more I say, I don't know. And the more, if ever, and as you said, Kathy and Rachel rightly, if I hear a patient having the slightest kind of blaming themselves for the cancer, I'm jumping and telling them, look, just emotional trauma usually don't cause cancer. You know, there may be a trigger, but they don't don't have any guilt complex, you know. So I think our role as a practitioner is to try to really, if possible, separate from the patient the guilt complex or something which is they created an emotional kind of relationship. Something can be a hatred, you know, they blame someone for their cancer. And their ability to heal. I think that, as you were saying rightly, emotions work both ways. They can be amazing source of pain and pathology, but also a source of healing, and releasing them is I think one of our clinical challenges, and helping patients on that. So I would like to thank, first of all, you all, you know, all the team here for taking the time and being with us. Thanking all the participants from everywhere. We will try to answer some questions also privately later, so obviously we can't cover all the questions. So thank you all for joining, and hoping to see some of you in the course that will give. All the very best, and be healthy. Thank you.
Thank you.
Thank
Thank
you.
you.